Hi there, my name is Joan and I'm an instructor with the ACCN program. This presentation is part 3 of a 4-part series covering materials in Module 5. In this presentation we will be discussing vasopressors, which cause vasoconstriction, increasing systemic vascular resistance. If you have not already done so, please watch the review presentations on adrenergic receptors, the autonomic nervous system, and determinants of cardiac output. Vasopressors are predominantly catecholamines and exert their effect via alpha-1 adrenergic receptor stimulation. Vasopressin is the exception, and its mechanism of action will be discussed shortly, and is the result of V1 receptor activation. The main effect that we are aiming for is to increase the MAP to improve organ and tissue perfusion. These medications are not without drawbacks, as there is a potential for significant adverse neurohormonal and cardiac effects. Adequate fluid balance should be determined prior to the initiation, as adequate intravascular fluid volume is necessary for the vasoconstrictive effect of these medications to improve perfusion. Medications that have a vasopressor effect include dopamine, epinephrine, norepinephrine, vasopressin, and phenylephrine. We have already discussed dopamine and epinephrine in the previous presentation on catecholamines. Norepinephrine has both alpha-1 and beta-1 effects, though typically alpha-1 receptor activation occurs at the doses prescribed. So the predominant response to norepinephrine is vasoconstriction and an increase in systemic vascular resistance or afterload. Because the effect of norepinephrine is mediated primarily by alpha-1 receptors, it is used in shock states where the systemic vascular resistance is low, such as septic or neurogenic shock. It may also be used to maintain a sufficient MAP to perfuse vital organs in hypovolemic shock. In all these shock states, fluid resuscitation is necessary. All the vasoconstriction in the world won't increase the blood pressure if there's nothing in the blood vessels to squeeze. As with epinephrine, norepinephrine is titrated to hemodynamic effect, with typical doses ranging from 0.03 to 0.5 mics per kilogram per minute. In severe cases, the doses can be increased past this, but outcomes are generally poorer. The side effects reflect the potent alpha-1 receptor stimulation and include tissue hypoxia, lactic acidosis, blanching and sloughing of skin along an injected vein, and if extravasation occurs, it can cause tissue necrosis. Vasopressin lives inside us as antidiuretic hormone, or ADH, which is a naturally occurring peptide hormone secreted by the posterior pituitary gland, and its effect is to maintain cardiac homeostasis. Vasopressin acts on 3 receptors. So V1 receptors are located in the vascular smooth muscle, and stimulation results in vasoconstriction. V2 receptors are located in the distal convoluted tubule and the collecting ducts of the kidney, and stimulation increases water reabsorption. And then V3 are located in the anterior pituitary, and they stimulate corticotropin release. The net result from a hemodynamic perspective is an increase in afterload, increase in preload, and decrease in heart rate. The decrease in heart rate is related to reflex bradycardia because of the increase in blood pressure. It is therefore useful in the treatment of diabetes insipidus as well as septic shock. In the 2016 Surviving Sepsis Guidelines, they indicate that vasopressin can be of value in addition to norepinephrine, especially if there is evidence or suspicion of decreased endogenous vasopressin or catecholamine-resistant shock. The side effects with respect to vasopressin, reflex bradycardia, as I mentioned before, because it actually increases the blood pressure with the vasoconstriction, it can stimulate a bradycardia. Dysrhythmias, they recommend using it with caution in the residents with coronary artery disease, as it can actually increase the workload of the heart. The vasoconstriction can also cause tissue hypoperfusion and hepatic and mesenteric ischemia. When giving vasopressin, depending on what it's being given for, if it's for diabetes insipidus, it's given sub-Q. In septic shock, it's given as a continuous infusion. Unlike the other vasoactive medications, vasopressin is not titrated, but is rather delivered at a fixed rate. Phenylephrine is what we call a pure alpha agonist, in that it only stimulates that particular receptor through alpha stimulation. It increases peripheral vascular resistance or systemic vascular resistance, increases the BP, and may cause a decrease in heart rate related to reflex bradycardia. And it also increases myocardial workload, which of course is not something that we typically want to see. For its indications, we use it to augment blood pressure during procedures that require sedation. So a lot of sedation will actually cause vasodilation related to decreased stress, and sometimes you just need a little bit of alpha receptor stimulation to maintain that, that map. It also can be used in augmentation of blood pressure in low resistance shock states such as septic shock or neurogenic shock. Phenylephrine can be given IV direct in small doses for 1 or 2 time effect. Usually the doses range from 0.1 to 0.5 milligrams, or as a continuous infusion with the range of 0.6 to 10 micrograms per kilogram per minute. As with other vasopressors, the side effects are reflex bradycardia, dysrhythmias, and tissue hypoxia. So that concludes this particular presentation. These materials are also discussed on your website. And if you have any further questions, please contact your instructor.